Hello, everyone, and welcome to our Dermatology Power Hour. Today, we're going to be covering the 5 rashes that kill you and the 7 most common types of rashes that you're going to encounter in the emergency department. The point of this lecture is to just give you lots of exposure into recognition of those rashes. And we're going to go in depth into at least all 5 of the rashes that kill you in our skin module. So again, this class is intended for my students who are taking my skin, bone, and muscle module. So let's get started. So first, you have an unknown age child who's coming in today with her mother for a rash that's been going on for the last several days. And you can see it in the picture that it looks like kind of a weird rash. Rashes are infamously hated by most of the emergency department providers. And that's because the list of possible causes goes on forever. But there's something I want you to notice about this differential. And that is, it doesn't really matter. None of these rashes are rashes that are going to kill this patient today. That's one of the best parts about dermatology in the emergency department. If it's not something that's going to kill you, then we don't ever need to do a stat dermatology consult. We typically almost never admit patients for rashes. So the ones that are going to be big bad that need to kill you, those are the ones that we need to know. Those are the ones that you need to study. If it's not one of those 5, and I might add a 5.5, then we don't really have to be able to differentiate. And it's not something that you should kick yourself about later. That's always something that you can refer out to a dermatologist or a pediatrician or a family practice doc, right? So, a couple of questions for what to ask and how to chart. So you need to ask about big systemic symptoms, things like fevers, things like review of systems, because a lot of times there will be a dermatologic component to an actual systemic disease. Vasculitises in particular are infamous for this. So you want to make sure not to initially blow off all of the rashes. We have to make sure that this is just a rash, right? We also want to ask about itching and upper respiratory tract symptoms. It's really important to document your distribution of the rash because that's often how we determine what the cause of the rash is. Any kind of new medications and new exposures. Now, it's also important that you know your vocabulary, and this is where a lot of people get confused. I'm not going to go through that today because I know that I have quite a few exercises in the module to help you with your vocabulary. But here's an intro picture in case you need some sort of reference. But again, if you don't know this, I'm not going to be teaching this in this particular lecture, so make sure you review that. Now, what we're going to go over today, and I'm going to try to do it in one go, is the quick function of the skin, the 5 rashes that kill, and then the 7 most common rashes. So here are the 5 rashes that kill. Okay, we're going to go through each of those specifically. And here are the 7 rashes that we see most commonly in the emergency department. So let's go over the function of the skin. The skin is one of our biggest organs in our body. Look at how much it's taking up of our body weight. It's 15% of your entire existence. That's more than how much water weight you have, right? Skin is a huge organ, and even though it's kind of ignored pretty frequently, it's important to remember that it's important. The functions of the skin, this is not an exhaustive list, but it's what makes us waterproof. It helps us with temperature regulation and waste excretion. That's why we sweat, right? It also helps us make vitamin D, which we can't do without our skin. It's also protecting us from infection with bacteria and weather and even UV rays. That's why we get tan. Plus, it's cushioning us to prevent deeper structures from getting injured. And it helps us gather sensory information, right? That's the whole idea of touch. Skin actually gets way more complex than this, but remember, that's for our derm folks. I just want you to appreciate what skin does. And there's really no better way to appreciate what skin does until you get a burn. Once you get a burn, boy, you remember how appreciative you were of having uninjured skin. So let's talk a little bit about how burns kill us. It's the damage of the skin that is the problem, but it's actually not what causes people to die from burns. People die from burns by three distinct ways: either infection, because there's no skin barrier or immunological protection from the outside world; dehydration, because we can no longer control our evaporation of our water and all of our water just evaporates; and then also electrolyte loss, because we can't control our sweating anymore. These are the three ways that skin and the rashes that are going to kill us are. I guess this is the three ways that the rashes that kill us do kill us. When we talk about burns, it is really important that you understand and are able to guess the degree of the burn by just looking at it. So remember that a first degree burn kind of looks like a sunburn. It might be splotchy or red. It's going to be hot to the touch. And then a second degree burn is going to be significantly worse. Usually is going to have some blisters or some sloughing of the skin because it's going to be significantly deeper. And then the third degree burns, those are the big scary ones. That's going to involve dead tissue. Usually the burns are going to be all the way down to the fatty layer or worse. We're also going to see carbonization, and that's the blackening of that skin. So when you're documenting first, second, or third degree burns, it's important that you document can't like how you know this is a second degree burn, because you can see blisters or skin sloughing. You can even describe third degree burns as non-painful, which means that the nerve is dead, or you can use the word carbonization. That's another word that we're looking for. Some old school docs use the word eschar, but that's kind of frowned on nowadays. So I would use the word carbonization. Now, we also have to talk about total body surface area, or TBSA. I'm sure you've seen these little graphical representations of an adult and a pediatric and how much each body part is in the total body surface area. It is important to guess and to document in any burn or in any severe rash what the total body surface area involved is. And again, notice that these are different in pediatrics versus adults. Typically, the dividing line between the two is around 12. So if you're in the gray zone, you can make a better guess on whether the patient looks more pediatric or more adult. Now, the total body surface area was actually originally kind of initiated by the Parkland folks, who developed their Parkland formula for rehydrating folks with burns. The more skin that's burned, the more of the evaporation that they're going to experience. And we wanted to um, be able to know how much fluid to give to those burn patients. Now, if you're not familiar with the Parkland formula, I highly recommend it. A lot of the exams are still testing on Parkland formula. It is of note that in clinical medicine and a lot of the burn units, they're getting away from Parkland formula because, as we discovered, one formula doesn't fit all. That said, there's going to be a whole bunch of exercises in the modules about this, so I'm not going to go into it in deep. What I do want to share with you is my cheater version of total body surface area. When you're in the emergency department and you're pressed for time, it's sometimes really hard to go ahead and look these up because I don't have them memorized, in all honesty. So, one of my best cheater methods is to look at the patient's hand, not your hand. Their palmar surface is about 1% of their total body surface area. So if I know that and I can look at the patient's hand, I can guess how many handprints is involved in the coverage of that rash or that burn. And that's how I kind of cheater my way through total body surface area if I have to guess in under 10 minutes without having time to look anything up. So it's something that you guys can apply in practice if you want. Now, when we have burns, You need to know when they should be transferred or admitted to a burn unit and when they can be treated by you and go home. So typically anything that is less than 1% doesn't need any burn treatments, right? And anything over 1% total body surface area, typically it's just pain that's the issue. So we're giving them Silvadene cream to help with the pain and to prevent infection. And then we also want to give them a little bit of fluid resuscitation, or at least educate parents or family members that this patient needs to drink extra fluids. This is true even of really intense sunburns, right? Fluid resuscitation is a big factor. Now, we're going to admit to a burn unit if we have 15 to 20% or more. Now, it's important that you know that burn units do not count first-degree burns. So that means it has to be blistering, you have to have sloughing, or there has to be some kind of carbonization in order to count towards the total body surface area. Now, there are some specific exceptions to that, and that is if 5% or more is third-degree burns, then that's going to count as a significant burn, and that probably needs to be transferred to a burn unit. Any genital, completely full circumferential burns, right? Because if it's the complete whole arm, and even though that's less than 5% or whatever, the scarring of that is going to cause some significant vascular and lymphatic problems. Any kind of significant facial burns, any kind of joint burns or thumb burns. And this is all due to their function later in life, because this burn is going to scar and cause problems. So if it's a total joint, that joint will no longer move once it scars down if it's not taken care of appropriately. And same is going to be true of the thumb. And that's why those are transferred to the burn unit. Any kind of electrical or inhalational burns, specifically like blast burns, are burns that you need to also transfer to the burn unit. And then if you have any kind of significant secondary factors, like maybe there's an infection going on or something like that, if you're ever in doubt, just contact the burns unit. Usually those folks have somebody on call who can at least talk to you over the phone, and then they can help make a decision. So in burns, what do we need to watch out for? Specifically infection, right? Dehydration, which we've already talked about. And then also we need to worry about function, right? So you can see the picture of the hands. If they can no longer move any of their fingers, that is a burn that I would 100% transfer to a burn unit, because that's going to require a significant amount of care. Same is going to be the person who is above. I would be very, very worried about intubating that person, and that person definitely needs to be transferred. I would also hesitate to intubate that person because I don't want to make their burn worse, and I don't know how far down it goes. I would be calling anesthesia for that person. Next part of burn therapy that you need to know about is something called an escharotomy. I'm sure you've heard of this. It's important for you to know that we do not, I repeat, do not cut anywhere on the joints. It's really important that you notice that. It's also really important that you notice that all of these areas are on the side of the body, and that only the areas involved should get cuts. You don't cut everywhere on the body. You only cut the areas that need it. And the whole reason that we do these escharotomy is because as that skin that's damaged starts to heal and scar down, that can cause a compression syndrome. So it can prevent the person from taking in a deep breath, or it can prevent the blood supply from getting into the toes or into the fingers, etc. Now, before we get into all of these rashes, I thought I would let you guys know this is pretty old school, but in medical school, this is what I was taught about rashes to know. SMART kit is the mnemonic that was taught to me in medical school. I know that there's several others, but I'm not a mnemonic person. And some people are, some people aren't. But in case you are, this is one of the many mnemonics that were taught to me of rashes to really worry about. Instead, I'm going to go with my original organization. So let's go over the 5 deadly rashes. The first one is the Steven Johnson spectrum. So there's three different types of rashes that are considered in the Stevens-Johnson spectrum. And I want to talk about what makes them all similar, what makes them all in this spectrum, and then we'll talk about what makes them different. I do have to add one tiny little addendum here, and that is in the research that I did after I created this lecture, there is quite a lot of grumblings in the dermatology world about maybe taking erythema multiforme out of this spectrum and making it its own sort of entity. This is something that, as far as I know, hasn't been done yet. But in case you're watching this lecture years from now, it's really important that you know that this may no longer be considered in the Stevens-Johnson spectrum. So, what's in the spectrum? So first of all, you're going to get a flu-like illness, usually fever with runny nose, and just generally body muscle aches, not feeling well. Then, after you get that fever, you start getting a peeling rash. And then you can get things like pneumonia or sepsis or multiple organ failure. Notice that the rash is going to look like this. It's going to be all over the body. Usually nothing is spared. You're also going to want to notice that it almost looks like a targetoid with a red middle and then a white ring and then another red ring. So these are called targetoid lesions. These are specific to erythema multiforme, but they can be seen in all different areas of the spectrum. All three of these also involve mucous membrane involvement. So that doesn't just mean on the inside of the mouth, like you can see pictured here. It also means inside the lungs with lung sloughing. It can be on the corneas or the eyes, inside the nose, or even inside the genitals, like the rectum or the vagina. So it's important that you check these things because mucous membrane involvement is one of the defining characteristics of the Stevens-Johnson spectrum. Next thing that you should be aware of is something called the Nikolsky sign. Now, Nikolsky sign means that you just take a gloved finger and with normal gentle pressure, not crazy amounts of pressure, but normal gentle pressure, you just drag your thumb or finger over the skin. Very firmly, but not too hard, right? The idea here is to initiate and see if there's any sloughing of the skin with minimal effort. If the skin starts to peel off with minimal effort, that is a really bad sign. There are several different of these rashes that I'm going to talk about today. They're going to be Nikolsky sign positive. So you should know what that means. And you should definitely always do this and document either Nikolsky sign positive or Nikolsky sign negative in your chart. Okay, so here's a little infographic on multiple different stages of the Stevens-Johnson spectrum. It's important that you know that you could be seeing a late stage or you could be seeing an early stage, and definitely always have this one in the back of your mind. So here is the spectrum with the three different rashes. I also want you to know that the spectrum is often called mucocutaneous hypersensitivity disorder. I'm not sure if they're going to switch over that or not, but until they do officially, I'm calling this the Stevens-Johnson spectrum. So notice that there's going to be lots of different defining features, specifically the fact that erythema multiforme is eventually able to go home. Stevens-Johnson's has to be admitted, and so does toxic 10. It needs to also be admitted. I also want you to notice that the targetoid lesions could occur in any of these, and the severity of illness and the amount of your body that is involved is increasing as we go through the spectrum. So here is an example of erythema multiforme. Notice that we have the mucous membrane involvement as well as the targetoid type lesions. Notice that this is not urticaria. These are not typically itchy, but these can occur anywhere on the body as well as involving the mucous membranes. Here is an example of also mucous membrane involvement. You can see around the lips. You can see it's also involving the palmar aspect And this is a Stevens-Johnson syndrome. And finally, you can see how much of an area this person has involving their entire back and most of their front, and there's a lot of sloughing going on. Some of these look worse than others, and this is definitely a 10. So here's some differences between erythema multiforme and some Stevens-Johnson. You can see that Stevens-Johnson has not only progressed to the entirety of this baby's body, but you can also see that the targetoid lesions have gotten more severe, and you can no longer see the white ringed outline. You can also notice that the biggest difference here is the total body surface area. Stevens-Johnson is defined as 10% or higher, whereas the defining line between Stevens-Johnson and 10 is 30% or higher. So the numbers to know are 10% and 30%. So here is an example of all of these in the picture. You can see again, less than 10%, 10 to 30, and 30. Here is an example of a tongue that is involved, and I want to bring to your attention the idea that this is going to cause problems with intubation if intubation is needed. If you are putting a gyroscope or a Mac blade or Miller blade into this person's mouth, it will very easily slough off, like we talked about the Nikolsky positive, and that's going to cause a big issue with intubation. So it's important to think about maybe not paralyzing these patients or calling anesthesia early. Here is this spectrum one more time, and I want to talk about some of the differences of the causes of these drugs, or sorry, the differences of the causes of these rashes. So you can see that on the lighter end of the spectrum, typically infection is what causes it. And then on the more severe end of the spectrum, drugs, specifically pharmaceuticals, are what causes it. So the infections that are known to cause erythema multiforme are mycoplasma and herpes simplex. And then the medications that are most likely to cause 10 are anticonvulsants or anti-seizure medicines, and then some antibiotics, and then NSAIDs. And typically this starts about a week to a full month after starting the medications. So this isn't like the first time they take it. It's not like a typical allergic response. That is really important to know. A lot of these medications are not necessarily listed in the warnings that they can cause SJS or TEN. So just because it's not on the warning label or it's not an easy, quick lookup fact, it is important for you to know that there are lots of different medications that can cause these. So because of that, a lot of the folks with 10 are just taken off of all medicines, all of them. So the treatment for this typically ends up being just like burns. So we're going to give them hydration via the Parkland formula or according to their total body surface area, whatever formula that your hospital is using. We're also going to stop either the offending drugs, specifically if they're on anti-seizure or antibiotics. But a lot of times, if you're not sure, we stop all medicines. And then finally, if it's over 10%, right, we're going to admit because that starts being Stevens-Johnson syndrome. And it's important to know that steroids don't help. All right, now we covered the Stevens-Johnson spectrum. So let's move on to our next one, which is melanoma. Melanoma is pretty common. It is 30% on men on their back. So lots of good things to know. And it's also really important to know that it occurs in people of all colors and races, and that the darker the skin, a lot of times the more missed melanoma is. So it's important that we need to recognize this in all colors of skin. So first of all, melanoma doesn't look too bad. Usually it looks like a real dark mole or really hard to tell that there's anything worse going on underneath. But you can see in this little cartoon picture that it disseminates very quickly into the surrounding tissues. And it's really hard to tell from the surface what's actually happening and how far it's progressed. So, in order to identify suspicious moles or markings, we do the ABCDE. And I realize that we have an ABCDE of trauma, but apparently we really like the alphabet in medicine. So, these are the concerning findings that we need to look for or that you need to ask about if you have an area that you're concerned with. So, you want to find something that's asymmetrical, something with jagged borders, something with abnormal colorations within the same area, something where the diameter has changed, right? Or something that's bigger than the end of a eraser. And then also that it's evolved over time. Okay, so you can see some examples of some not concerning findings versus concerning findings. And in case you want to see another one, here's another example of normal and then melanoma. Now, some of the tricks of melanoma that I want you to be aware of, particularly in dark skinned individuals, is that melanoma is very easily found sometimes on the soles of feet and then also in the nails. You can see these dark, jagged areas in the nail beds or on the palms or soles of feet. Another area that you need to know about is that melanoma likes to metastasize. It gets into the blood and it goes all over the body into weird places that you would never expect, that we never really think about when we think about metastatic cancer. Melanoma is very, very common to go into the brain, into the eye, and you can see these pictures here of melanoma in the iris. Now, granted, all of them are light eyes because it's easier to see, but this happens the same amount in dark eyes too. And it also is very infamous for going into the heart muscle itself. Melanoma goes into the heart muscle. And this can lead to tumors and eventually cardiac death without realizing that it was actually melanoma that killed them. So once we have metastatic melanoma, you can see from this graph above that the survival rate goes down drastically. So what we want to do is we want to detect melanoma early. Okay. So the 5-year survival rate is awesome if we can detect it early. And this is why we want to educate you into knowing what melanoma looks like and what to look for. All right, let's move on from melanoma into autoimmune diseases. And luckily, there's only 2 of them that are really presenting with primarily a rash, and that is pemphigus vulgaris. So think of it as a vulgar pemphigus, right? So this is going to be itchy, typically appears in elderly, and is going to be 90% fatal if it's untreated. Notice that you're seeing the sloughing of the skin. It looks very blistery. And this is going to be Nikolsky's sign positive. It's going to be very easy for these areas to slough off. It's also going to involve mucous membranes. I'm not sure if you're seeing a pattern here, but I'm just pointing it out. And this is going to be an antibody, because remember, it's an autoimmune antibody against your desmosomes. And I'm going to have a picture of that here shortly. Now, this is a mimic of pemphigus vulgaris, and this is called bullous pemphigoid. This occurs in your significantly older adults, so we're talking over 70, and it's usually in flexures, but it can occur anywhere. As you can see, this is on this person's back, and unfortunately, this person is not over 70, but there's a reason for that, and I won't talk about that here. The important part about bullous pemphigoid is that you can see the blisters or the bulla are not easy to rupture. So if you walked up and you just touched it a little bit, it wouldn't rupture very easily. And that means that it's bullous pemphigoid. This is not a fatal rash. While it's not pretty, that's something that can be referred to dermatology. Whereas if you walk up to a blister and you pop it very easily in an elderly patient, we need to be worried about pemphigoid vulgaris. So again, this is pemphigus vulgaris. Notice that it's occurring inside the mouth. You can see it in this underarm, and the bullae are usually very easily burst. So that means a lot of times we won't even see the bullae by the time they get to the emergency department because they've already been ruptured. So here are pictures of what desmosomes are versus hemidesmosomes. So to clarify, the ones that kill are the desmosomes, autoimmune connecting to each cell, whereas hemidesmosomes are the ones that connect to the bottom layer. Okay, here's a pathology picture of pemphigus vulgaris. And so you can see that all these cells have let up and they've let loose. And then here is a handy dandy chart comparing the two because they look so similar. Notice that one of the biggest differences is the Nikolsky sign and how easily the bullae rupture. That's really where the secret in these two lie. If you can pop it or if the skin sloughs very easily, that's bad. If you can't, you're probably doing okay. Typically, we treat these folks with steroids, unlike the Steven Johnson syndrome, right? And then there's all these other medicines. A lot of these medicines are antibody related, like plasmapheresis, or even cancer therapies like rituximab or cyclosporin. All right, so we covered some deadly autoimmune diseases. Now we need to cover the three deadly infectious diseases. So let's go through those really quickly. The first is toxic shock syndrome. So this one was made particularly famous in the 60s and 70s because women who left their tampons in were getting toxic shock syndrome. While that doesn't happen as much anymore, we do still see it with nasal packing in the elderly that's left in too long. This is really important to remember because remember that it's usually caused by one of us because we didn't tell the elderly folks to take out their nasal packing. So definitely be on the lookout for that. Here are the signs and symptoms of toxic shock syndrome. So you're going to get the high fever, headache, vomiting, joint pain, low blood pressure. So it's like pretty much just sepsis-y, typical infection signs. Very vague. That's what makes it so hard to figure out. This is usually caused by a certain strain of strep that lives in cotton. And the rash will not occur until all of these signs and symptoms have happened first. So here is an example of a toxic shock rash. It looks very cellulitis-y. It looks very diffuse. This is also going to be Nikolsky's positive. Again, notice this trend. And you're going to see all of the desquamation and the hypotension that's associated with like sepsis, for example. Okay, here is another example of some famous causes. And this is a famous model who suffered an amputation of the leg because of toxic shock syndrome. That is something that you're welcome to look up. I think it was a couple of years ago, 2018 maybe. At the end stage of this, you're going to see something like this that looks like the worst sunburn you've ever seen all over the entire body. Notice that it's not wet or weepy, but it looks like almost a dry, crusty layer all over the skin of a really terrible sunburn. This is usually end stage toxic shock syndrome. This means that we're going to have death in like 24 hours or so. So these patients need to be recognized early, although it's hard to recognize them early. So if you see a rash like this that looks like a really terrible sunburn and they say they've had a fever in the last few days, or they've had hypotension, or they just feel bad, I would definitely be admitting them for IV antibiotics and get that started sooner rather than later. Now, this is in direct similarity to staph scalded skin syndrome, which is why I consider them very similar. So what I want to point out is that the old school docs used to call this Ritter's disease. But as it turns out, that gentleman was involved with the Nazis. So now we don't commemorate him any longer. The difference between toxic shock syndrome and staph scalded skin syndrome, besides the fact that these two are usually in opposite age groups, is that one is caused by strep and one is caused by staph. That's really the only difference between these two disorders. So you could have somebody in the middle age who has either staph scalded skin or um, toxic shock syndrome. Now, there's a reason why staph scalded skin is usually in the children, and that's because it's caused by the exotoxin of staph. And most of us in adult life have already been exposed to staph's exotoxin, and we have good immune systems related to that. That's why we almost always see this in children who are under 3. So you can see that this is occurring mostly in cracks and fissures around the mouth, the eyes, and the nose. This is also going to be Nikolsky's positive, but this one typically doesn't involve the mucous membranes because the bacteria itself isn't necessarily the infectious agent, it's the exotoxin. So we're going to treat this just like a cellulitis combined with a burn in the same way that we treat this as toxic shock. Okay. So there have been some interesting theories on this, and I'll let you do some research if you're interested. But some folks are saying that they think a lot of infants who get staph scalded skin may be due to umbilical infections. And this picture in particular shows you where the umbilicus is mostly the infectious source, as you can see here. So that's something that's being played around with. The adults that get staph scalded skin are often the folks who are on dialysis, not just kidney disease, but on dialysis. We think this has something to do with the fact that they must have lost their immunity to the exotoxin, but we don't know how that plays a role in, like, how does the kidney and it not functioning play a role in the immune system? Nobody knows. Maybe it has to do with the way that we dialyze or an infected dialysis kit. There's a lot of work being done on this too. We don't know. We just recognize that adults with staph scalded skin are most always on dialysis. All right, let's go over neck fash and gangrene. All right, let's talk about necrotizing fasciitis or the flesh-eating bacteria. So the truth about necrotizing fasciitis is that most of it is caused by more than one bacteria. Usually it's some kind of strep with some kind of anaerobe. This is something that's very serious. This kills within hours. I'm talking about 6 to 8 hours. So we don't have a lot of time on this. So if you're suspicious of necrotizing fasciitis, you need to consult surgery early. And you need to be particularly aware of this in people who are immunocompromised. The patients that I've seen with necrotizing fasciitis are folks with IV drug use, folks who are diabetic, or folks who are on chronic steroids. But there are lots of other immunocompromised individuals who are at risk for this, like HIV folks, cancer, et cetera, et cetera. And there have been several cases reported in very young, healthy individuals. So always have neck fash on the back burner. Typically, we see folks like this have tachycardia and low sodium. They also have pain out of proportion. So that means like you touch and it's not a very impressive physical exam, but they are just wigging out. It hurts so much. We also like to do x-rays for this, looking for air under the skin on an x-ray. I'll talk about that here in a second. Neck fash is one of those bigs, do not miss rashes. Here is a necrotizing fasciitis, and you can see how quickly this spreads. This is on a leg, and it doesn't really look that bad, but when you touch it, the patient is just freaking out. We think that the bacteria gets through the skin through open wounds or punctures, and they're eating the connective tissue of the skin, and they're actually putting out gas, which is where what the anaerobes do, and that's how gas builds up underneath the skin. So here's a picture of a really not bad looking rash that hurts way more than it should. And somebody did a CT scan, and you can see in this picture of the CT scan how much air is underneath the skin. And you can see how much tracks and how high up it does. This black area, that's the gas. So that simple rash is actually considerably worse than it looks. And that is something that you need to call the surgeon on like several hours ago. There is a criteria that has been developed recently called the Linrich criteria that can help you determine whether a rash is a necrotizing fasciitis or not. So I'm going to let you guys review this if you're interested. This came out after I was in medical school, but it is a really cool, handy criteria to make sure that you're not calling the surgeon every time you have a rash, right? When we treat these, again, it's a surgical washout immediately and really intense broad spectrum antibiotics. We're talking about Vanc and Zosyn and big guns. All right, now we got to talk about our last one, which is gangrene. So here we have a picture of gas gangrene that looks very similar to Fournier's gangrene. Right? Fournier's gangrene is always of the testicles and the penis, and it's almost always occurring in diabetics. This is something that is very, very commonly missed with a diabetic who has belly pain, and he's too afraid to tell you that his scrotum hurts. And unless you look, you won't find it, and this patient can die. You can see the air underneath, again, in this CT scan. Here's another picture of necrotizing fasciitis versus gangrene. Okay, so this picture is actually of gangrene. This was not neck fash. But what I want you to see is that neck fash is usually caused by strep pyogenes combined with some kind of anaerobe, and it usually progresses within hours. Whereas gangrene is usually caused by Clostridium, and it is usually progressive in days. So neck fash is clearly the winner here. So I wanted to come up with a good definition between wet gangrene and dry gangrene. So you can see here that dry gangrene looks like these toes are mummified, right? They're black. There's no pain by the time we're reaching this point because the tissue is dead. The bone is often dead. There's no blood flow to the area. This has probably been going on for months. The treatment for this dry gangrene is amputation, which you could probably walk up and pull off one of those toes, right? But the important part is this is not an emergency. This is something that you refer to vascular surgery. You could send these people home. Wet gangrene also occurs for months at a time, but it's often weeping, sometimes can be infected, and you can see that the tissue isn't quite to the stage of dry gangrene. It's still in the stages of dying. So the tissue is still somewhat viable, but not quite. And that makes wet gangrene considerably more painful than dry gangrene. Wet gangrene can also end up getting infected. The bacteria eats away the tissue that is still alive, and so wet gangrene may require antibiotics. Wet gangrene is also very similar to, if not the exact definition of a diabetic foot ulcer. So typically we want to determine whether somebody needs antibiotics. We want to consult vascular surgery. Whether they need to come into the ER or not is completely up to you and that patient. We need to help the patient with wound care and sugar control if they're diabetic. And then, of course, be careful getting x-rays on these because a lot of times the radiologist will call osteomyelitis when it's actually just dead or dying bone. So something to know for in case you get an x-ray. All right, the last big deadly rash that we need to know about is anaphylaxis, which isn't really a rash at all. So you need to know that somebody with anaphylaxis typically has some kind of redness or skin swelling going on. And this is different than an allergic reaction because anaphylaxis is defined as 3 or more organ systems involved. So that means that the rash is going to be one organ system because it's the skin. So they could also have something like hypotension, that's the cardiovascular system. But they don't have to have hypotension. They could just have wheezing, or maybe they could have nausea and vomiting. That's the gastrointestinal system. Or they could just feel impending doom and anxiety, and that's going to be the neurological system. So you can see how very easily you can come up with 3 specific organ systems. If in talking to this patient, You're getting 3 different organ systems. Don't mess with anything. Don't wait for hypotension. Just give them an epi IM, not sub-Q, IM. Go ahead and give them the usual Benadryl, Pepcid, and steroids as well, but go ahead if there's 3 organ systems and give them that EpiPen. If you completely reverse the anaphylaxis and the patient is feeling better, all of the symptoms have resolved, and you've monitored them for at least 2-hour period, you can send them home with an EpiPen script and steroid burst. All patients with anaphylaxis that I see get referred to an allergist. So you can see this little girl is also having anaphylaxis. They're raising her legs to try to get her blood pressure to come back up, and they're giving her some oxygen as well. The important part is that anaphylaxis can happen due to any kind of intense exposure or allergy, and we don't waste time in anaphylaxis trying to figure out the cause. We need to treat the patient first, figure out the cause later, especially because most patients don't ever discover the cause. And now we can finally get into the 7 most common rashes in the emergency department. So we have completed all 5 rashes that kill us. And now we're moving on into the 7 most common rashes. So we've already kind of talked about burns, but I do want to talk about some very specific burns. Then we're going to cover some specific viral rashes, bacterial rashes, fungal rashes, insect rashes. We'll talk a little bit more about allergic rashes, and then we'll talk about the not rashes, right? So we've already talked a little bit about burns, but there are a few special burns that you need to recognize. The unfortunate truth is burns are often the medium for which children are being abused. If you see at the very top, those are cigarette burns. You can see that that there are certain burns that you need to recognize as dunking burns, or the child with the stove markings on their face. You can see the cartoon of the child that has the quote unquote zebra stripe or donut hole of the child that's been dunked into really hot water. Those are all non-accidental burns that need to be reported. Those children need to be admitted, even if the burns aren't that bad, because we don't want them going home with those parents. I also want to bring up one other special kind of burn, and that is pictured in the bottom. In car accidents, it's very common to get a burn from the airbag. You can see burns on the thumb side or the forearms, even if there was no fire reported in those accidents. It's also important to note that a lot of motor vehicle accident patients can often get burned from the talcum powder that's used to store the airbag. That powder will then go into the eyes and they can cause eye burns. So please know that you can get eye burns from a airbag deployment in a motor vehicle accident. All right, let's move on to the 2 type of viral rashes we're going to talk about. So the first is I know it's kind of a cop out. I included quite a few rashes that I'm referring to as viral exanthems. These are the most common cause of rashes in all of pediatrics. And the truth is that while sometimes you can determine what is causing the rash, like the sandpaper rash of strep, for example, or adenovirus, because it almost always involves a conjunctival rash as well. I tend not to worry too much about these unless they're measles or rubella or something like that. I don't waste a lot of time IDing these because these aren't going to change my management. You can always have them follow up with the pediatricians in the office if the parents are particularly worried about it. Typically, we just need to treat their fever. One of the viral rashes that we do need to know about on site is shingles. We often hear it called the hurt that rashes because especially in adults, you'll see that it hurts first and then the rash will come. Notice that all of these rashes are unilateral only. If you see that it spreads to the other side, it is 100% never shingles or herpes zoster, right? They're the same thing. They usually describe these as a dewdrop on a rose petal, which you can see on the bottom right picture. But most of the time, you won't get to see these pretty dewdrops because a lot of times they've been itchy, they've been hurting. And so the patient has either scratched them off or they've burst. And so you actually see them as little spots without vesicles on them because they're itchy and they hurt. These zoster is something that you always need to recognize. It can happen in any age patients, pretty much from 20 and above. And we're seeing less and less of this now that there's the chickenpox shot, but we do still see it. It's important to know how to treat it. You can choose between acyclovir, which is a very cheap medicine, but you have to take it 5 times daily, and that's a hard ask for a lot of patients. So typically we prescribe valcyclovir, also known as Valtrex. It's a little bit or a lot of bit more expensive, but you only have to take it 2 times a day. So if the patient has insurance, I typically prescribe Valtrex because it's higher compliance rate. Steroids given for the first week can help with the pain, and it can also help to keep the infection in a localized area. Gabapentin is also helpful for the pain, and it's important that you know that nothing makes the pain go away all the way. You can also get a post-herpetic pain syndrome where they have pain for even up to a month after the rash goes away. It can be very painful. Opiates do not help. Let me repeat that. Opiates do not help with shingles. I highly recommend that you don't give them opiates, although a lot of doctors will give them because they feel bad for the patients. Please notice that this can happen anywhere in the body. You're going to see it in the mouth. You can see the bottom picture has only on one side of the mouth. You can have it on the genital area. There's multiple areas that it can come out. You got to know 2 different special signs or syndromes with shingles. The first is Ramsay-Hunt syndrome. It's pretty much shingles of the ear. You can see that top picture of the little pustules inside of the pinna of the ear, combined with like Bell's palsy type symptoms because that facial nerve is being compressed. The scary part about Ramsay-Hunt syndrome and the reason why we care about it is that the complications of Ramsay-Hunt syndrome are pretty severe. Things like herpes, meningitis, myelitis, encephalitis, Guillain-Barré syndrome, stroke type syndromes, and beyond. So it's really important to recognize Ramsay-Hunt syndrome and have them appropriate follow-up. You also need to know about herpes, the Hutchinson sign. Hutchinson's sign is the shingles on the tip of the nose. Notice that there's an arrow sign pointing to the tip of the nose. Okay. If there are a breakout on the tip of the nose, that is the exact same nerve as the nerve that innervates the cornea. So it is a very highly likelihood that if it's the tip of the nose, there's also herpes on the cornea itself. That is what we care about because if you stain it, you'll see dendritic lesions, which are pictured here, and that causes herpes zoster ophthalmicus. This can lead to blindness. This has to be treated with special eye drops, and it is important to get them in to see an optometrist, an ophthalmologist today, right? They don't need glasses, so no optometrist. They need an ophthalmologist today because we don't want them to go blind. So this would be a patient that you would need to transfer out or call in your ophthalmologist. All right, we covered some viral rashes. Let's go on to the big bacterial ones. The first and most obvious one is going to be cellulitis, right? That's an infection of the dermal skin layer. It's most commonly caused by some kind of scratch or hair follicle that got infected that then spread to the surrounding area. It's almost always defined as red and warm. It's going to be tender to the touch. Usually it gets very swollen when compared with the other side. Can involve fevers and thickened skin. Usually it's going to be unilateral. It's very rare to get bilateral cellulitis. And there's many different kinds depending on where it's involved in the body, right? So you can have periorbital cellulitis in children. That's the top picture. Or you can just regular have hand cellulitis that's pictured in this man's picture in the middle. You can tell the difference between cellulitis on ultrasound. We will get to that a little bit later. Cellulitis is almost always easily treatable by Keflex, other cephalosporins, or penicillin, specifically augmentin. You can also, if you're concerned about MRSA, which is not as common as you guys think, you can give Clinda or Bactrim. It's important for you to know that in typical regular old-fashioned cellulitis, you should always try outpatient antibiotics before admitting them, because most patients do very well with oral antibiotics for about 7 days. I want to point out to you that this is bilateral, and while it is red, it is not hot, it's not thickened, and it's not particularly tender. That's because this is peripheral vascular disease. It is not cellulitis. I really want to make sure that you understand that there's a difference between those two. Here are some reasons why. There's another mimic, which is gout. So which one is cellulitis and which one is gout? There are the answers. It's a little bit different than what you thought, right? This is because just looking at a foot, you cannot tell the difference between gout and cellulitis. Let me say that again. No matter how experienced you are, you cannot tell the difference between gout and cellulitis. How do we tell the difference then? Look at these. What do you think? The answer is both are gout. The only way that we can tell a difference is either by doing an x-ray, by doing joint aspiration, and by combining history with the patient's experience. If they say they had gout before and it's exactly like the gout they've had before, then maybe it's gout. However, if they've never had gout before, then it might actually be cellulitis. So experience here is not about your experience. It's not about how many years you've been practicing. It's about the patient's experience. So it's important to know that practitioners cannot see a difference because there is no visual difference. You have to do this by lab testing, joint aspiration, or patient experience. Here's another special kind of cellulitis. It's called lymphangitis. Some people consider it cellulitis, some people don't, but either way, it's actually an infected lymph node. This is something that is almost exclusively diagnosed because it'll start streaking, because it starts following up the lymph pathway. This needs to be treated aggressively with IV antibiotics, because where does all lymph end? Lymph dumps into the subclavian vein and then eventually goes back to the heart. So if that streaking infection goes and dumps into the bloodstream, not only are you going to get bacteremia, but then you're also going to get an infected myocardium. You can get endocarditis or myocarditis or other significantly serious infections. So you want to admit these patients for IV antibiotics to stop the progression, rather than sending them home if it's already this close to the chest, right? Another quote unquote type of cellulitis is impetigo. These are going to be the oozy, honey colored crusts, typically around the mouth and the nose of children, although it can be in any area. It's almost always caused by Staph aureus. It's typically never resistant, which is why we give amoxicillin or Omnicef. And these are almost always okay to discharge. This is usually preceded by like a runny nose in a child, and they are not the cleanest, so they keep rubbing at it or they let it get infected and the skin breakdown happens right underneath that nose area. Impetigo is also very common in bedbound patients, so it's something to definitely look out for. One of the other, I guess, diseases of the skin that we have to figure out that is different than cellulitis is abscesses. Abscesses actually have a collection of pus underneath the skin. So where cellulitis will often have a fever, abscesses don't often have a fever. To differentiate between abscesses and cellulitis, you want to feel the area, and you want to feel and document both the words indurated and fluctuant. So indurated is what cellulitis is also. It's the entire area is full of fluid, like inflammatory fluid. That's why the skin is thickened. And then fluctuance is specific to abscesses. Fluctuance is like a filled water balloon underneath the skin where you can kind of slosh it around. That's the pus. If you don't feel fluctuance, you shouldn't cut it open, right? Abscesses do not get better with antibiotics alone. Let me say this again. Abscesses do not get better with antibiotics alone. That equals malpractice. You will lose that case. You need to have those patients use warm compresses and get an incision and drainage. I am not going to go really deep into abscess care for this lecture because it's long enough as is, but I will be uploading an abscess lecture shortly. So if you're interested in that, definitely keep an eye out. So that means that we only have 4 rashes left. Let's go into fungal. These rashes are kind of ill-defined. A lot of people call them ringworm, tinea, athlete's foot, diaper rash. There's a million of them. All these are fungal infections, usually itchy, usually in areas of sweat and moist and damp. And typically if it's moist and damp, it needs to be dried. If it's dry, then it needs to be moistened and dampened. Steroids always make fungal infections worse. I do know that they make tubes that have antifungals with steroids in them. I think that is absolutely ridiculous. Please be aware of those. Do not recommend them. This will definitely only temporarily make fungal infections better, and then they tend to rebound 5 times worse than they were before because steroids decrease your immune system. So we don't want to give anybody with a fungal infection a steroid. Now, a specific type of fungal infection is Candida. Candida is probably one of the most common funguses we see, and it's very specific because what we can see is satellite lesions. So you can see in this baby diaper rash that there are tiny red spots around it. It's not just clearly demarcated, there's just multiple tiny red spots. Those are satellite lesions. Same with this area under the breast here. Candida is the most common cause of diaper rash. It's also the most common cause of thrush. You can see it in the mouth here. It's also the most common cause of jock itch. That's why typically topical is the best, and we want to give nystatin for Candida. Other fungal infections, you can give other fungal treatments, but nystatin is specific for Candida type infections. And if you want to make sure that it's actually a candidal infection, look for those satellite lesions. The last big fungal infection that I think is really worth your time to know, it's really sad, but it's called a carrion. These are all pictures of a carrion, which is caused by a really intense fungal infection of the head. These are almost always in children. And you're going to notice that it's always occurring in a circle. They're raised and boggy. A lot of times they weep. They look like they have almost like pus-like spots or seepage, but they are not a bacterial infection and they are not an abscess. Do not cut these. Do not give antibiotics because they won't work. You have to give a medicine called oral griseofulvin for 6 to 8 weeks. That's right, I'm talking 2 months because of how deep the fungus goes. Notice that you're also going to see that the hair in that area is fallen out. Don't worry, it'll regrow, but it's really important that you know the difference between a carrion and a typical tinea capitis. So in all these pictures, like this one, and this one, you can see there's only one area, it's a circle and it's raised. This picture on the bottom here is multiple areas. It's not raised. So this is not a carry-on, this bottom picture here. This is a true tinea capitis. That can be treated with regular antifungals and that'll go away no problem. The other three actually need the oral griseofulvin and they need it for the full 8 weeks. Okay, so moving on. All right, let's do some insect rashes. So not all insect bites are infected or treated. Beware of the spider bites because most of the patients who say it's an infected bug bite or spider bite, it's actually an abscess and that has nothing to do with the spider, okay? So if you see multiple bites or you actually see the bite marks, that's when I believe it's an insect bite. Benadryl helps with itching, cool cloths, not itching it, and then of course, decrease exposure by wrapping it are all usually helpful for insect bites, right? Almost no insect bites need antibiotics. Let me say that again. Almost no insect bites need antibiotics, so don't give them, okay? Here are a whole bunch of examples of specific bites. You can see spider bites and tick bites and mosquito bites, right? It's really good to recognize these. It's a really positive thing. The ones I want to point out the most are tick bites, because of course we're going to be worried about something like Lyme disease. But outside of Lyme disease, we're not going to be treating with antibiotics. Scabies is an insect bite that you should come to recognize. It almost always starts in skin fold areas like between the fingers or underneath the arm, and then it can progress to everywhere. This is something that you will see. It is something that occurs on a lot of homeless folks and can be really difficult to tell between meth scratching and scabies. It is important to know that scabies are often overdiagnosed because people look at rashes, they don't know actually what it is, and they end up saying it's scabies. So do your due diligence, actually look at the rash. If you think it's scabies, encourage the whole family to have treatment and include washing of towels and linens and toys. The treatment for scabies is permethrin cream. That's only about $26 without insurance. And you can put permethrin cream on twice and you leave it on for about 12 hours and then you wash it off. It is important not to put permethrin cream on the face. All right, let's move on to allergic. The first and probably second most common rash that we see in the emergency department besides viral exanthems is urticaria. Urticaria are itchy, they're temporary, they occur suddenly, and they're raised. Notice that they're coming up out 3D style off the skin. Usually they start in certain little patches and then they can kind of congeal like that top picture into like a big red plaque with like a weird non-delineated edge. It's important that patients call these hives, but when you document in your chart, you should call these urticaria because that's considerably more professional. This is almost always caused by some kind of allergic reaction. Usually things that are causing an allergic reaction, such as hives, is not going to be life-threatening as long as it's only the rash, right? So only the rash is not going to usually cause a life-threatening disease unless it's going to be anaphylaxis. It's not worth spending more than 10 minutes with the patient trying to find the cause of the rash because 80% of allergic reactions never find a cause, even with testing. So it's important to set up your patient's expectations, although they can decrease their limitations to new things. The typical treatment for urticaria is Benadryl, Pepcid, and steroids. And the worse the reaction, the more you can give IV versus oral. If they go home, it's considered standard of care to give them about a 3-day steroid burst to prevent a rebound reaction. And of course, it's just a kind thing to do to send them out with an allergy referral. These are two rashes that are not urticaria or hives. Notice that these are caused by scratching. I have seen many folks say, oh my gosh, look at that. It could be hives. And they treat these folks with the typical urticaria type treatment. Please don't do that. It's worth it to just go up and kind of scratch the patient's skin and see if some hive-like urticaria-like lesions arise. Because if so, you need to know that these is dermatographism. This is not something that can be treated. You can go to dermatology if they want, but this has to go away on its own. The other sort of allergic type of reaction is called dermatitis. Dermatitis is a very localized reaction, like an allergic reaction. So you can see in this picture here with the belt that they've developed this rash right where the belt touches the skin. You notice that this lady on the top picture, she has this rash right where a necklace would be. You can also see that dermatitises can be caused by many different things. You can see kind of skin thickening, and basically the skin is angry. This does include things like poison oak or poison ivy because it is a localized reaction to whatever's making the skin angry. Typically, Benadryl and steroid creams are the most helpful for dermatitis, so hydrocortisone cream is going to be your best friend. It's also important that you recommend that they stop with the exposure of whatever it is. So you got to tell that gentleman to take off his belt and not use that belt anymore. Or you got to tell the folks to stay away from poison ivy or poison oak, that kind of stuff. It's also important to know that poison ivy and poison oak can be spread, whereas these other dermatitises, unless they're rubbing that metal or whatever it is they're allergic to other areas, it's not spreadable. All right. And finally, we get into the last category, and that is the not rashes. So what you're going to see about these two pictures that I have for you is that they're labeled. Okay. The bottom one is called petechiae. Those are actually little bruises, little tiny areas of capillaries that have burst. So petechiae, while it looks like a rash, is not actually a rash. Same with purpura. Purpura are big bruises. So the difference here is in the size. These are actually the exact same thing. Both of them are bruises caused by some kind of vasculitis, right? The problem is with the blood vessel and it bursting. So typical vasculitises that we see with these kind of rashes are Rocky Mountain spotted fever, meningococcemia, and Kawasaki's. So this is an example of Rocky Mountain spotted fever. You can see it's only in the extremities because those blood vessels are considerably smaller than in the trunk themselves. If you go up to them and push on them, you're going to notice that they're not blanching and that they're flat. You're going to also notice that a lot of these occur on the palms and soles because they're actually bruises and not actual rash. So if you're going to have and see somebody with Rocky Mountain spotted fever, typically they're going to have a fever, headache, abdominal pain, diarrhea, and myalgias, just like every other viral syndrome ever. But you're going to get the rash about 3 to 4 days after the fever. Does that sound familiar? Here is the general cause. So you can see that rickettsia is the tick-borne illness. Here is the distribution among the United States. Some people live in high areas, some people live in low areas. The big scary thing that we have to worry about is you notice that this is not distributed where the Rocky Mountains are, and that the most common complication is hearing loss. And so we need to test these kids for that, or at least make sure the parents know and set up a hearing test maybe a couple of weeks after they get better. The treatment for Rocky Mountain spotted fever is doxycycline. And we want to give it into 10 to 14 days. This is the one time that we're going to use doxycycline, even in pregnant females, if they have Rocky Mountain spotted fever, even though that's a risk, because it's a higher risk to not treat pregnant females. The next big purpuric type area is meningococcemia. So I don't know why we differentiated it like this, but meningococcemia is meningitis with a rash, okay? And that is specifically caused by Neisseria meningitidis. So that specific cause of meningitis causes these purpuric big rashes. Usually it's 20 years old or younger, and we're getting these weakened blood vessels that tear. I want you to see the difference between these two. You can see one is more purple and one is more red. The more red one is called Hinoch-Schondlin purpura. We're going to talk about that in a minute. But you should know that meningococcemia is treated just like every other meningitis. You want to give them IV antibiotics with a steroid. These people are going to appear very ill. They're going to need to be admitted. You're going to need to do an LP. Although, if they have this rash with meningitis symptoms, LP is not required because you know the diagnosis, right? So just give the treatment. This is the most common, usually in the military barracks or in college dorms. But it is important to know that because a lot of people have shots for this now, this has gone down drastically in the last several years. So now quickly, let's talk about Hinoch-Schondlin purpura, not because it's a rash you need to know per se, but because it is so closely, it's a mimic, I guess, of meningococcemia. So these kids usually only have a rash on the lower extremities. If it goes above the butt, it is not Hinoch-Schondlin purpura. Typically, this is self-limited. They might have had a fever prior to this, but they do not have meningitis symptoms. And everybody with Hinoch-Schondlin purpura needs a kidney function test, specifically looking at the creatinine, to make sure that the creatinine is okay. If it's okay, discharge. If it's not okay, then a pediatrician needs to be consulted and they need to be admitted. The last big vasculitis is Kawasaki's disease. Again, there's going to be some more module information on Kawasaki's disease, but a lot of people know it by looking at the constellation of symptoms with the mnemonic crash and burn. You can read it here so you know. One of the big things that you need to know is that the fever needs to be more than 5 days. There are lots of different types of Kawasaki's disease, and there's a lot of new disorders being talked about as Kawasaki's disease. Here are some examples of the classic. The reason why we care about Kawasaki's disease is that the dreaded complication is coronary aneurysms in children. This is a picture of a heart of a child who obviously died with a large coronary artery aneurysm on the back of the heart. We are trying to prevent this. This is the one time that we're giving kids aspirin and IVIG. You should almost always order an echo and an EKG because we are specifically looking for that coronary artery aneurysm. And it's really important that if you find one, you get them admitted. I do want you to know that there are some partial Kawasaki's diseases being talked about. And some people are talking about how COVID-19 can actually lead to Kawasaki's disorders being activated. Again, that's sort of like new and in the pipeline. We'll find out in the next few years if that turns out to be true or not, but it's something to keep your eye on. So, in summary, we went over the 5 rashes that kill, and hopefully you can recognize all 5 of them. We also went over the 7 common rashes of the ER and the ones to know and the ones that you can send home. Important to know, we know how rashes kill through dehydration and infection and electrolyte loss, and we know how to prevent that. We know how to estimate total body surface area, and we know when people can go home or when they need to stay. We also recognize that not all rashes are true rashes and that we need to look for systemic diseases. That's why review of systems is so important. Lastly, these are some of the most commonly prescribed creams for rashes in all of medicine. So one of the most common fungal disorders is Candida, right? So this is the nystatin cream that we give. If it's a bacterial infection, you can give mupirocin or neosporin. If you need to give something for an autoimmune or a dermatitis, we want to give a hydrocortisone cream. And then if you have something like psoriasis or other kinds of chronic skin diseases, we want to give the Eucerin creams. Notice that these are not one tube fits all. You need to kind of have a general idea of what you're trying to treat, and you need to tell them where to go if it doesn't work after about 2 weeks. And in case you need some resources, I want to point out that Visual Diagnosis has an app if you're willing to pay the money to help you diagnose skin diseases. There's a bunch of information on burn statistics. And I want everybody to be aware of this project called Skin Deep. And this is the website that is free and available online. And they're trying to accumulate as many images of rashes on darker skin as possible. So that way, all of the textbooks aren't filled with white skin rashes only. So, something to kind of help us out with our racial understanding and to improve all of our practice. They are accepting images there, and it is free to all students and all providers. You just have to sign up with an email. So please take a look at Skin Deep. I have linked it for you in your module, and I think that covers it. Thank you guys, and I hope you join us next time.